Kia ora tātou. It's great to be here today. I'd first of all just like to acknowledge the Health and Disability, the Health Quality and Safety Commission for putting together such a wonderful program for today. I'd like to acknowledge the speakers that have gone before me and all the people that are here with a wealth of experience and commitment towards improving service delivery for all New Zealanders. I'd particularly like to...
Sorry, I was just going to put your slides up for you.
I'd particularly like to thank Linda, who's here beside me, who's been actually working with me on the project that I'm here to talk to you about today, and that is real-time feedback for consumers of mental health and addiction services and their family whānau. And it fits really well with the speakers that have gone before, talking about how much services have changed in mental health. I think Matt's talk about where things are at in Australia with the approach to dealing with depression is a good reflection of how rapidly mental health services are changing. I think also the TED talk and looking at the use of technology and how that's empowering consumers and how much potential it has for helping us change and develop services is really relevant to the project that I'm working on. Also, Nick and Ruth talked about the power of feedback, consumer experience in driving service change. And again, that relates really closely to the project that I'm in the process of developing. And I think Rowena and Graham's talk have really profiled the importance of having really good information for consumer representatives at the governance level and the power that it gives you for influencing change. And so this project is all about developing tools that will enable you to hear from a much larger number of service users, to be able to analyse and process that information and use it to feed into the planning and funding of future services to ensure that they better meet the needs of service providers. So just reflecting on Graham's talk, I have too many slides. I have 12 slides, and I'm going to move through them quite quickly because I'd like to leave a bit of time at the end for discussion. I thought that I would need to cover for you a little bit of basic background about my role and where I'm working. There have been some changes in the past, and I know that there are some familiar faces here from forums that I've been to before, but there are also quite a lot of faces that I don't know because this is right across the health and disability sector. So I thought I'd just give you a wee bit of context and then go on to talk about the actual project that I'm working on. So where I'm working at the moment now is the Health and Disability Commission, who's most of you will be familiar with them as the agency that processes complaints. So we hear all about when things go wrong for people. My role was as the Mental Health Commissioner was moved across was added to the statutory functions of the Health and Disability Commission nearly 2 years ago now, when the Mental Health Commission closed. And my role is not to process and resolve complaints, but it's to monitor mental health and addiction service delivery, and to advocate for systemic change to improve services. So it's very closely aligned to the role of the Health Quality and Safety Commission, and the work program that Janice talked about is again very closely aligned to the program that I've developed. So I've really covered this slide in terms of what I'm doing, so we've moved through that one quickly. And moving to the Health and Disability Commission, I had essentially the same responsibilities that I had when the Mental Health Commission closed, but had to scope a new work program where I would still be able to add real value to the sector, but with much diminished resources. The work program is figuratively represented in the slide you can see now. And essentially it involves developing relationships with the sector, so really close engagement with people that are using the services, their family whānau, and also service providers. And I'm having to do that now through national forums. Previously we did it face-to-face, and I had a lot of contact with providers through and people using services through sector visits, but I'm not able to do that. There were about 6 staff working on face-to-face engagement. As you move around the work cycle, I need to collect information around best practice, what's happening in terms of service delivery, how it's changing, and also how people are experiencing the services. One of the projects that I've decided to put some energy into over this year is actually developing electronic tools for enabling people using services, anyone that wants to provide feedback, to give them the opportunity of doing so any time that they're actually engaging with any of the services. And that's right across all services, from primary care through to those people that are admitted acutely into specialist services under the Mental Health Act. So it's so that people that are engaging with the services right across the spectrum have an opportunity to comment on them. This information is one of the sources of information that we'll then be able to use in order to advocate for service change. Of course, the other aspect of it is that it provides information for the governance groups, the consumer advisory councils, and other governance boards to understand what the experience and how well services are meeting the needs of consumers, so that they can make informed decisions in funding and planning future services. One of the reasons behind developing or giving priority to developing this system was that we all understand how important it is in terms of best practice to include the consumer experience and information around the consumer experience in evaluating how well we're doing. There's Janice talked at the beginning about the IHI quality improvement and the need for information on different aspects of service care, including its cost effectiveness and clinical outcomes, or clinical best practice and outcomes at the population level. But we also need to know what it's like as someone using the experience, whether it worked for them or not, whether their needs were met, in order to be able to design better services. Collecting that information on scale and giving everybody the opportunity to have input into it is ideal, but at the moment that isn't what's happening. If you look at the existing mechanisms for collecting information from mental health and addiction service users, there's a national consumer survey that the Ministry of Health has had in place for a number of years. It's a paper-based survey that is collected annually. The uptake is, I think the response rate is something like less than 30%, I think it might be 15%. The information that comes back from it is that there is about a 95% satisfaction rate. It's actually a satisfaction survey rather than consumer experience. And so what does that do in terms of driving service improvement? It has limited impact. So there is a survey that's been collected and there is historic information, but its usefulness is fairly limited. There are also a lot of local programs. Initially they've been paper-based ones, and there are now some that are developing that are electronically based. and there is a more meaningful information being collected from those surveys, but they're local, they're not national, and we're not able to get a picture of how well we're doing across the country, across all the DHBs and all of the providers, in terms of how well we're meeting consumers and the consumers' needs and their family whānau needs. One of the reasons why it's important for us to give the family or whānau an opportunity to provide feedback in mental health and addictions is because of the impact and the role that family whānau have on the recovery of people with mental health and addiction problems. You cannot think of an individual with mental health problems in isolation, and you cannot plan their recovery, the treatment that they will have, without engaging with the family whānau. And I think a couple of the speakers earlier today talked about that. Matt talked about the importance of, and I think in Australia they call them carers rather than family whānau. He talked about the importance of the role of family. So our survey has been designed to capture feedback from not just the users of the service, but also the people that are supporting them and living with them. So we're well underway in terms of, sorry, I haven't been clicking through my presentation, so there you go, I haven't been using slides. So where are we at the moment? The project's underway. We ran a national RFP process and selected CBG as the provider. Linda was on the panel, and it was a process that was generated a lot of excitement in the sector. People could see the potential of developing a real-time feedback process that would enable people to provide on tablets or other devices input on their service experience, for that to be uploaded immediately after they had contact with the provider, uploaded, and that information analysed and incorporated into real-time reports that both the provider could look at and the service user, the public, could look at. So really exciting project in terms of the potential providers. We chose CBG as our preferred supplier because of the experience that they have already working in the sector. They currently provide the National Health Survey, and they're also working extensively in primary care with developing feedback services around the quality of services that general practice is providing on a national basis. We contracted with them to develop the system and to pilot it. The pilot is going to be undertaken with 7 sites. We've chosen the sites pretty much in the northern half of the North Island, largely because of the constraints, the time constraints and budget constraints. But we have 7 pilot sites that are representative of all providers. 3 of them are DHBs. We've got Northland, Waikato and, it's 4 DHBs. Northland, Waitemata, Counties Manukau and Waikato. Those DHBs have got multiple sites within them that they'll be piloting the information collection. For instance, Counties Manukau is partnering with an NGO that provides community-based specialist services, and they'll also be having their peer-led services involved in the pilot. The 3 NGOs that are involved, one is Taruki Health, which is a Maori primary care provider in Counties Manukau. Another is Youth Horizons, a residential NGO service for youth. And the 3rd NGO is Odyssey House, which is an addictions provider. So we've chosen the pilot sites to try and get a real range, a real cross-section in terms of the populations, the type of services, and the age groups that we want to be able to ask relevant questions of. We've established an advisory group to oversee the project. It of course involves a consumer advisor and a family whānau advisor, as well as experts from a range of services, and includes the Health Quality and Safety Commission. Linda is on the expert advisory group. We've been working closely with Health Quality and Safety Commission because, as you'll hear, Richard is going to be talking about the work that they are currently leading in terms of capturing consumer experience from the rest of the inpatient services, but not mental health. Mental health and addiction has been excluded from the work that they're doing. But we are working very closely. We're building on the work that Richard has done, looking at the question sets that we should be using that are validated and most meaningful. But rather than just picking up the set that Health Quality and Safety Commission are using, we're engaging with consumers and family whānau at the moment to ensure that the question set we use is relevant and appropriate for them to be able to feel that they've been heard and to talk to us about the issues that are important to them. So this is a diagram that really captures the project. You can see the top left-hand quadrant is around engagement with consumers and family whānau around the design of the survey tools to make sure that they're appropriate. The pilot also involves, on the right-hand top quadrant, the development of the software and testing the technology to ensure that it's able to be used by the providers on site and also where they're providing services remotely. There are a range of devices that can be used. It can be done on a laptop, on kiosks. We're actually using like an iPad tablet for the pilot. And during the time that we've been developing and scoping the pilot, the cost of these tools have come down to about $85, which makes it possible for virtually any provider to be able to afford to be part of this process as we roll it out. So really exciting in terms of the ability for providers to participate in this going forward. The bottom right-hand quadrant is about developing the reporting. So once we've collected all this information using questions that are appropriate, we need to be able to generate reports that are going to be meaningful and able to drive change. So at the moment we're looking at the functionality of the reporting, how people can access them, what the reports will look like, how much control a provider has over the type of report that's generated and who they can be automatically sent to. So the reporting functionality will be really important for driving change. One of the things that I find really exciting about it is that it's using all sorts of different tools that I wasn't even aware were available. Like, for instance, people can go onto the site and make commentaries around changes in the data. Like if you see, for instance, that people's response to a particular question changes quite significantly as a result of an intervention that providers have made, people can put on the report a comment about what might have generated that change, so that when you look at it, you can actually see what might or might not be going on that's driving those changes. The other thing you can do is you can set up standard reports to go out to various groups. Like if you've got a monthly meeting of a governance group, you can have a report that's generated every month to go out to be automatically emailed, that is a real-time report on how things are tracking from the feedback that you're receiving. And so that will just go out automatically without anyone having to do anything. And then the last quadrant, the bottom left-hand one, is what I think is the most important one, and that is integrating it into your quality improvement practice at the provider level. So making sure that information that's being generated is actually driving change, and that you're then being able to look at what the impact is in terms of the consumer and family whānau experience and the feedback that you're getting. So question set development. I've talked a bit about making sure that we're building on the work that health quality that Richard's been doing, and what we've decided to do is to take from the 20 questions that the Health Quality and Safety Commission have used, to take the ones that we believe are most relevant for talking with mental health and addiction service providers, to take a core set of 5 of them out and to consult to engage with consumers and family whānau about whether they are relevant and what other questions we should be asking. One of the most important feedback to date has been that people want to be able to use free text. They want to be able to say if they feel they're being respected, why in particular they feel that it was a good experience, or if it was a bad experience, why it was a bad experience. And that's generated some issues around, okay, how do we make sure that someone picks up on any alerts in terms of if people are at risk, or if they want to be able to talk to someone about what's happened to them. So we've had to build into it functionality so that if people would like to be contacted, they can be, or if we believe that they're at serious risk of self-harming, that there is someone that will actually contact them. So we are expecting to have feedback from CBG. The feedback is on the question set is fairly soon. I think it's later this week. So these are the draft questions that we're consulting on. By later this week, we will have agreed what questions we'll be actually piloting. And exactly how many. We think that 20 from the research we've done, 20 is too many for the mental health and addiction sector. We want to keep it to a lesser number. But by later this month, we'll be starting to go live, rolling out the question sets through the devices, actually in the pilot sites. So next steps in April, as I've said, we'll be finalising the question set. May to July, we'll be rolling out the question sets and testing the devices and the software, and also the reporting and getting feedback from the pilot sites. We've also contracted an independent evaluator to provide us with advice on how we might actually do better with the system that we've developed, so that we're able to develop a plan to roll it out in October that's going to build on the learnings from the pilot to date. So after October, we'll be in a position to let people know how we're planning on rolling it out nationally. The concept is that HDC will be paying for all of the infrastructure, and that it will be possible for service providers up and down the country to acquire the devices, to engage with us around setting them up so that they can have them in their services. Whether we do it hundreds of services at a time, or whether it's a much slower progression, I'm not sure at this stage. But if you want to know what's happening, we have a communications plan that has started with communication information for the pilot sites, but will very rapidly expand into letting anyone that's interested in knowing what we're doing know more about it. You'll be able to just go on to the HDC website and find a link that will take you into the CBG website on the pilot, that will have information on, more detailed information on the nature of the project, and also some of the results that are being generated. So on that note, I wondered if we have any time for questions.